Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. For this episode of the Interventional Glaucoma podcast, we're heading back to the 2024 European Glaucoma Society Congress in Dublin to join host Professor Gus Gazzard and guests Dr. Nishani Amerasinghe and Dr. Jose Belda as they discuss the concept of routine Phaco Plus and its impact on clinic efficiencies and patient outcomes. Let's listen in.
So, welcome to the next episode of the Interventional Glaucoma podcast, brought to you by Elios Vision. I'm Professor Gus Gazzard from UCL and Moorfields, and I'm today joined by Dr. Nishani Amerasinghe and Dr. Jose Belda from Alicante. We're here to discuss Phaco Plus, which is the idea of adding a MIGS procedure to cataract surgery with the hope of reducing intraocular pressure and all the potential benefits that can bring. So, Nishani is the president of the UK Glaucoma Society, consultant at the University Hospital Southampton NHS Foundation Trust, and a full-time surgeon based down there in Hampshire. My other colleague here today is Dr. Jose Belda from Alicante in Spain, with 20 years experience of surgical glaucoma and working in clinical and hospital centres across the world, and some experience also in cataract and refractive surgery. So both Dr. Nishani and Dr. Jose, I think, are excellent people to join us here today to really explore the range of opportunities that adding a MIGS procedure, whether that's Elios or one of the other procedures available, to cataract surgery. And so what I'd like to do is to start with what we mean by Phaco Plus. Well, Nish, why don't you kick off? What does Phaco Plus mean to you as a concept?
Well, I think it's being able to offer a patient, at the time of cataract surgery, a procedure which is safe and effective to lower the pressure or to get them off drops while they're having their cataract operation.
What do you think the main outcomes or advantages of a Phaco Plus type approach are in the way you see managing glaucoma?
The main advantage of doing Phaco Plus for me is safety. As long as the patient is going to take the risk of the surgery, of the cataract surgery itself, and this is not going to add new risks, I think it's a good option to try to reduce the number of drops or even remove all of them.
So safety first is, I think, our main criteria with our MIGS procedure. I totally agree with you. What do you think are the specific gains that we have from adding some procedure, whatever that might be? What is it Phaco MIGS doing for you? You've already mentioned reducing drops. What else?
Apart from the reducing drops, we can add the quality of life of our patients, which is much better. We have to think that most of the drops have secondary effects, like effects onto the surface of the eye, and also systemic effects as well. And we might not only improve the quality of life of our patients, but even the expectancy of life. I mean, if you are removing the beta blockers, for example, you might find that those patients have better living conditions.
So there's local side effects and there's systemic side effects.
Yes, that's right.
And I think I'm a huge believer that we underestimate the impact on quality of life of a lot of our medical treatments. I mean, the number of patients I've treated with something and then removed the drop and had them say to me, unexpectedly, I feel so much better, whether that's a beta blocker or an alpha agonist. What about you, Nish? What's driving your uptake of Phaco Plus?
Well, I think the points that Jose has already said are very valid, improving quality of life, but also it's been shown that it's effective at stopping secondary incisional surgery in the future. So you can buy some more time for your patient. There's visual field data as well.
And those are both some quite robust
Exactly.
Robust RCT studies, aren't they?
Exactly. And so we've got good data, which is really important, good data to show that these are effective, not just with quality of life reducing drops, but also on the glaucoma management.
How would you describe the situation in the UK at the moment, both in terms of where we are now, what the availability is, and also what the understanding is?
I think within the glaucoma world, the uptake of Phaco MIGS is increasing. Most units now have some form of MIGS surgery that they can offer to patients.
I think that was certainly my hope when I was the UK Glaucoma Society president, that we'd managed to reach that point already. I think now what we need to do is try and sort of refine it and help people so they've got a wider choice of procedures.
Completely agree.
And what about in Spain, Jose?
Spain is very complicated, Fred. We're living like in 17 different countries in terms of health governments. Every region has its own government, so they have to approve the different devices that can be implanted in each region. For example, where I live in Alicante, we are very close to Murcia, which is a different region, different community. That I have people that live just 15 kilometers away. They cannot come to my hospital, and they have not allowed not even iStent or any other type of Phaco Plus.
So there's huge regional variation.
Yes.
Even within very small distances.
Yes, that's the point.
Wow.
So it's a bit difficult. How can we have, let's say, more homogeneous treatments for the whole Spain? I think it's a matter of politicians, but it's getting worse and worse.
Practically speaking, what does that mean that you're doing for your glaucoma patients? Are you offering Phaco Plus to everyone? Are you offering Phaco Plus to only the more severe disease? How does it work?
So for us, because we've got a quite big team of glaucoma surgeons, we are offering Phaco Plus to those patients that have cataract. So for a glaucoma patient that requires cataract surgery, we will consider Phaco Plus. We will have that conversation with the patient. If it's very advanced disease, it may be not appropriate. But again, it's about managing the patient's expectations or looking at the patient as a whole. It might be that actually doing a Phaco Plus procedure before a trabeculectomy, maybe in certain cases, the thing to do. But in our moderate and mild patients, yes, we're...
So anyone who's on medication for pressure, who's having cataract surgery, you'd consider for a Phaco Plus procedure.
Yes.
I think that's very similar to what my practice is in London. I'm also interested in how people talk about, oh, it's not for severe disease or it's only for mild to moderate disease. And if you're going to be taking out a cataract in a patient that might have a trabeculectomy later, you've got a possibility that you could get target pressure with a Phaco Plus procedure, even if it's only a small possibility. So what I find myself doing is making that offer of a plus procedure to pretty much anyone, irregardless of their severity, because I can't predict who's going to have a big pressure response. Yeah. And sometimes I'm very pleasantly surprised. But what I try and do is manage the patient's expectation.
And that's what it exactly has to be. You've got to manage the patient's expectations. So if you're in there doing a cataract operation and you've already explained to the patient that they're probably going to need a trabeculectomy down the line, however, there is actually another procedure that's safe, that may be effective while we're doing the cataract operation. Shall we go ahead with this? If it works, excellent.
But I think that you have also taken into consideration the target pressure you want to get.
Yeah.
I mean, if you have a patient that is coming with 40 with the maximum treatment, I would probably not offer a mixed procedure to him. We'll go to trap or deep spectromy or something that I know is going to bring the pressure much lower.
But I would maintain that those patients who are 40 on maximal tolerated medical treatment are relatively few and far between. We often quote them as an example. Far more common is my patient who is perhaps slowly progressing on 3 medications, a combo plus a prostaglandin, say, and they've got a bit of cataract. And they're slowly progressing, and I'm thinking, well, I'd really like their pressures to be under 15, or I'd like their pressures to be in the low teens, with or without meds. And some of my colleagues will do a trabeculectomy. I would be doing a Phaco Plus procedure, trying to get them down as low as possible on the minimum number of meds, but tell them this is a staged journey.
Yes.
This is going to be the first step. Your next step might be trabeculectomy. We could do it the other way around, but this is what to me makes sense. I think we have a sort of multi-dimensional graph. We always think about trade-offs between safety and effectiveness, but we've got to think about safety, recovery time, effectiveness in very different ways for each individual patient. So it sounds as though your practice in the south of England, mine in central London, are very similar.
If, as you said, if we can manage and control the glaucoma with very little risk, why not? So it's a very good option for our patients. So I offer that to all of them. The thing is it possible to do it in all the patients? I think that the answer is no, because some patients are still very conservative and they don't want to go to new things. Just get rid of my cataract. I don't want anything else. I will go on with my drops. I find that in some of the patients.
Oh, that's interesting.
I'd still offer it.
Yes,
though, you would,
yes,
yeah.
yes. And privately, because I also see private patients,
Yes.
it's money.
Yes.
Because sometimes you have to offer them, and this is the cost of the cataract surgery. This is the cost of the cataract surgery plus, and it's not the same, and it's much more expensive. So some patients will decide, okay, I prefer to pay for the drops.
Yeah, I mean, that is unfortunately, that the cost does come into it inevitably. I think where I have cost-free decisions, I'm offering it to everyone. There are questions that are often asked at the end of symposia and such like, where people say, well, how would you define the cataract plus patient? And my answer is always a bit glib. It's a bit simple. It's, well, anyone who's on pressure lowering drops.
I agree.
Yeah.
You see, because I think increasingly, certainly across Europe, we're there. I mean, Phaco Plus, are we there yet? I think we're there in terms of sufficient scientific rigor and randomized controlled trial support for the principle. What I think we haven't refined is exactly how we're going to pay for it, justify the cost effectiveness, and maybe the decisions around which one we use.
But my question is, are we there? I mean, we are glaucoma surgeons, and we are convinced about this treatment. We know that it works.
Mm-hmm.
We know that it will cause benefits to our patients. But how about the rest of our colleagues? Do you feel that, for example, in your department, do all the glaucoma surgeons do the same? Because it's not the same with my colleagues. I mean, we don't have like a protocol. We don't have like a guidelines to say this is the standard procedure. This is what we have to do with all of our patients.
No, we certainly don't at Moorfields. We still have, I unkindly call them dinosaurs, but we still have some colleagues who choose not to add a plus of MIGS procedure to cataract surgery. And I never understand why, because when you ask them about it, they don't have a strong evidence-based justification. I think there are now randomized controlled trials supporting the use of stenting devices, bypass devices, excimer laser trabeculotomy, ostomy devices and procedures are all being increasingly supported by RCTs. So yeah, I think it's very difficult to support not offering that. I'd agree with you.
Yeah, we've got 6 consult senior surgeons, and we're all offering Phaco Plus. We may not offer the same technique, same MIGS procedure, but we're all offering Phaco Plus.
I mean, we're still working on a lot of that data collection, aren't we? I mean,
yes, I agree. I think we do need more data. There's no doubt about that. But I think we are there with the studies behind it to show that it's effective and safe to do Phaco Plus.
I agree with you. I always picture myself when I am going to do a Phaco Plus, just staring at the different options and having like a roulette. Which one is going to be? So I think that this is something that will change in the near future as long as we have the results of those clinical trials, for sure.
So it sounds as though from what we're saying that there are occasionally there's patient reticence about having an additional procedure done when they're happy with medications. Sometimes there's patient reticence because of the cost of that additional procedure in certain environments. But I think there's also reticence from colleagues who are looking after glaucoma patients and taking out their cataracts to learn treatments when they see glaucoma surgeons who aren't necessarily agreed amongst themselves as to what the best procedure is. So I'm hoping that we'll move towards a world where all this robust RCT evidence really supports those choices much more, and we can really refine which group of patients at which level of risk with which level of pressure will respond best to which procedure.
Yes, I agree. I mean, I think we are there with Phaco Plus, but it's now which patient needs which procedure. That's where we need the data.
Thanks very much, guys. That's been great. That's really helped us today, I think, explore some of the justifications for Phaco Plus, some of the limitations or the boundaries and the decision-making behind it. And also, I think we can see that we really are very close to it being the gold standard that we should be offering to all of our patients, and that many of the reasons people are not getting Phaco Plus is probably situational or organisational. In fact, it's a sort of systemic problems and a matter of choice rather than a matter of science.
Yes.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by Emlaze GmbH, and the Fido laser applicator, manufactured by Vinert Fibre Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.